Good morning. We're going to go ahead and get started. My name is Kay Vavrina. I'm here with my co-moderator and co-worker, Elliot Chang. We are here for our second nutrition workshop, Nutritional Breakthroughs, a workshop on evidence-based nutrition. The goals of this workshop are to discuss emerging research on gastrointestinal dysfunction in individuals with CF, with a focus on how disease progression and CFTR modulators influence intestinal health. Our first presenter will be Dr. Nicole Green. She is an associate professor of pediatrics in the Division of Gastroenterology and Hepatology at the University of Washington and Seattle Children's Hospital here in our host city. Welcome, Dr. Nicole Green, to discuss her work on fecal metabolomics and markers of intestinal integrity in individuals with advanced cystic fibrosis liver disease and the effect of ETI, results from the PROMISE study. Dr. Nicole Green.
Good morning, and thank you for inviting me to speak today. It's a wordy title, so I won't repeat it. For disclosures, I have 2 Cystic Fibrosis Foundation grants that support my research. So this table is just to highlight that liver disease is common in people with CF and is increasingly recognized. My focus here is advanced cystic fibrosis liver disease, and by that we define as cirrhosis and portal hypertension, and then non-cirrhotic portal hypertension, which refers to those people who have minimal liver fibrosis but evidence of portal hypertension. So you can see portal branch venopathy, splenomegaly, thrombocytopenia. Advanced liver disease occurs in about 7 to 10% of people with CF. It's associated with significant morbidity and is a leading cause of non-respiratory related death. And currently, we have no treatment options to prevent the development or progression of advanced liver disease. Before we can think about treatment, though, it's important to try and understand pathogenesis, and that is not clearly defined. The classic theory, though, is you have intrahepatic biliary obstruction from dysfunctional CFTR, which is expressed in cholangiocytes, and this results in inspissated bile flow, accumulation of toxic bile acids, and this ultimately leads to liver inflammation and fibrogenesis. What I'm most interested in is the gut-liver axis theory, which refers to absorbed bacterial and inflammatory products from an altered GI tract and increased intestinal permeability. And this also likely contributes to that non-cirrhotic portal hypertension or portosinusoidal vascular disease, as you get inflammatory influx from a leaky gut. But this last entity is thought to be also a vasculitis, endotheliitis, or a microthrombosis etiology. So the gut-liver axis, to go into that in more detail, we have heard a lot about the leaky gut in CF. There's increased mucosal inflammation and ulceration. There's overgrowth of pathogenic bacteria and increased small intestinal permeability. And the idea here is that you get translocation of these bacterial factors into the portal circulation, resulting in liver inflammation and fibrogenesis. And this can also probably have an impact on the portal vein, resulting in inflammation. We've heard also a lot about intestinal dysbiosis in CF. So there's descriptions of decreased species diversity, delayed maturation and altered functionality, loss of protective and anti-inflammatory species, and an increase in bacteria associated with inflammation and colorectal cancer. What contributes to this dysbiosis? It's definitely multifactorial, so altered or mutated CFTR itself, which is expressed in the GI tract, results in a thick mucus, intestinal dysmotility, a lower intestinal pH, and then iatrogenic factors such as repeated or chronic antibiotic exposure contributes to an altered bacterial composition. And this likely plays into the intestinal inflammation that we see in CF. And if we're following the gut-liver axis theory, contributes to liver inflammation and liver disease. So as stated in the title, I was looking at results from the PROMISE study, which is a prospective multi-center observational study to measure the effects of ETI in people with F508del mutation. and I was in this study, part of PROMISE was looking at 12 and above. I was focused on the GI and liver sub-studies, as those in the GI sub-study had stool collected as part of PROMISE. We defined liver involvement based on labs, physical exam, liver histology, and where available, and imaging where available, and defined advanced CF liver disease, as previously described, as either non-cirrhotic portal hypertension or cirrhosis with or without portal hypertension, and matched these individuals to controls who are also enrolled in the PROMISE GI sub-study, so had CF but no clinical evidence of hepatobiliary involvement, and stool and serum samples were collected from subjects before and after initiation of ETI. So this is the breakdown of the advanced liver disease subjects. We had 8 with cirrhosis, 1 with cirrhosis and portal hypertension, and 2 non-cirrhotic portal hypertensions. So 11 overall, and overall we only had 2.5% of PROMISE participants who had advanced liver disease. So when we decreased our denominator to those involved in the GI sub-study, we ended up with 11. And this is just a demographic table showing the advanced liver disease cohort and the CF no liver disease. And as you can see, quite well matched, but AST, ALT, GGT, and markers of liver fibrosis scores were higher, as you might expect, in the liver disease group. This schematic is just going over the study design. So we had 11 with liver disease, 23 matched controls. And stool and serum were collected at baseline, and then 1 and 6 month post-ETI. The stool, we looked at microbiota, targeted metabolomics, short-chain fatty acids, and fecal calprotectin, which is that measure of intestinal inflammation. And then the serum markers of intestinal integrity were intestinal fatty acid binding protein and claudin-3. The microbiota work has previously actually been presented and published, so I'm not going to talk about that here. But for those interested, the fecal metabolomics was performed using a targeted panel measuring about 360 metabolites. And then, as you can see here, we did the fecal short-chain fatty acids, fecal calprotectin, and then serum ELISAs for intestinal fatty acid binding protein and claudin-3. This is my only slide on statistical analysis, so please don't ask me too many questions. But we looked at differences in overall fecal metabolome profiles using principal component analysis and random forest, and p-values were calculated using mixed effects models. And then to look at, or try to identify individual metabolites that were driving overall differences, we used partial least squares discriminant analysis, and then multiple validation criteria were applied for the PLSDA results. So in terms of the results, first of all, looking at baseline, were there differences in fecal metabolite profiles between the liver disease and no liver disease? And the answer was no. And just to orient you, the PC1, PC2, these are actually p-values for the 2 components. Then we asked, well, what about if we just looked at the liver disease individuals who had cirrhosis, so excluding those 2 with non-cirrhotic portal hypertension? And then we did see a slight difference in the metabolite profiles at baseline. This is a heat map looking at specific metabolites that were statistically differing in abundance between the liver disease and no liver disease, and this is for baseline. And I'll show a few heat maps. These are generated based on PLSDA, and I'm just going to highlight a couple of things on each of the slides, or else it would take too long. So things I thought were of interest here, PAF-C16 was higher in the liver disease group at baseline. This is a mediator of inflammation. It's produced by inflammatory cells and induces increased vascular permeability. And then caffeine was also higher, but this is sort of an expected result as we see decreased caffeine clearance in individuals with cirrhosis. Metabolites that were significantly lower in abundance. Hypoxanthine might be of interest. It promotes intestinal wound healing and strengthens intestinal barriers. So that was lower at baseline in the liver disease group. Comparing the two cohorts again following ETI, this is all liver disease versus no liver disease, and no differences in overall metabolite profiles, at least no statistical appreciated difference. Looking at the cirrhotics, again, we did then appreciate a difference when we excluded the non-cirrhotic portal hypertension individuals following ETI in terms of differing fecal metabolite profiles. Another heat map, just again looking at metabolites significantly higher in advanced liver disease post-ETI, and we're seeing again PAFC16, that inflammatory mediator, and caffeine. Lower, I thought this was interesting, and this is a lower in CF cirrhosis after ETI, so S-E-methylselenocysteine is actually a chemoprotective metabolite. It has anti-tumor effects, it induces apoptosis, and has antioxidant activity. Looking just now at the advanced liver disease group and looking at shifts in metabolite profile with ETI, at least based on PCA analysis, we did not appreciate a statistically significant difference. And then looking at metabolite shifts with ETI among the liver disease cohort. So on the left heat map are the metabolites that significantly increased in abundance, and on the right, those that decreased. So cysteine increase, this is a precursor to cysteine, which is required for glutathione synthesis, which is an antioxidant. So, just trying to build a story here, increased levels might suggest decreased consumption due to less oxidative injury or reduction in inflammation. And then metabolites that decreased, it was interesting that now with ETI, we're seeing PAFC16, that inflammatory mediator decrease, as well as neopterin, which is also a metabolite that indicates a pro-inflammatory state. Deoxycholic acid is a secondary bile acid produced by gut bacteria, so lower levels with ETI might suggest improved bile acid malabsorption. We did see more of a shift with ETI in the no liver disease cohort, and that was statistically significant. And then, as you can see here, a lot of metabolites driving differences. So these were the metabolites that significantly increased with ETI. We're seeing this same chemoprotective metabolite. And then those that decreased were similar to the liver disease group, or the same, neopterin and PAFC16, these inflammatory mediators significantly decreased with ETI. We surprisingly, or at least surprising to me, did not appreciate any differences in short-chain fatty acids between the liver disease and the no liver disease, and no changes with the ETI. Moving on to intestinal serum markers of intestinal integrity. So intestinal fatty acid binding protein is a marker of intestinal epithelial cell damage, and we did not appreciate in either group an improvement with ETI, but worth noting is that in non-CF studies, a level around 180 is considered normal. So both groups here had significantly elevated FABP, suggestive of compromised intestinal integrity. Claudin-3 is also a marker of intestinal integrity, and again, no improvement in either group with ETI, but again, both the liver disease and no liver disease had elevated levels with sort of non-CF controls thought to be around 5 as a normal level. Then we asked, were any differences that we did see driven by differences in clinical response to ETI? So we looked at calprotectin. Did the liver disease and the controls perform or respond differently to ETI in terms of changes in intestinal inflammation? And the answer there was no. And calprotectin does decrease, but not different among the two groups. And then the same using sweat chloride as a surrogate of clinical response, no difference in response between the two groups in terms of response to ETI. And then FEV1, they both seem to respond similarly to ETI based on FEV1. So in conclusion, when including all liver disease phenotypes, we did not appreciate significant differences in fecal metabolite profiles between the liver disease and no liver disease at baseline or following ETI. But when we looked at just the cirrhotics versus the no liver disease, we did see some differences. Concentrations of metabolites associated with inflammation decreased in both groups with ETI, as well as this cysteine, this amino acid required for antioxidant synthesis, increased in liver disease, perhaps suggesting a decreased inflammation and decreased consumption. The secondary bile acid, deoxycholic acid, decreased in advanced liver disease with ETI, reflecting improvement in bile acid malabsorption. There were no obvious differences or changes in short-chain fatty acid profiles. And while baseline intestinal fatty acid binding protein and claudin-3 measurements were higher in the liver disease group, there weren't significant changes with ETI. So ETI does not, at least in the short term, seem to improve intestinal integrity, and any changes did not correlate with other measures of clinical response to ETI. Obviously, this was a very small sample size, particularly those with advanced liver disease, and we only have sort of short-term 6-month follow-up data. But despite the small data set, I think this study might highlight some areas to focus future research, so metabolites associated with inflammation and oxidative stress. This is the work of many very smart people that I would like to acknowledge here. So Luke Hoffman, who is a pulmonologist, but somehow got roped into being in charge of all the poop for the PROMISE study, and the members of his lab, and he's also my mentor, as well as Mike Narkowitz, who has mentored me for a long time, specifically around CF and CF liver disease, Hilary Hayden, who's in Hoffman's lab, and has done a lot of this work and analysis, Adrian Verster, who I will direct you to for any biostatistical questions, and he is fabulous but couldn't be here today, and then the Raftery lab, the Sagal lab, the PROMISE study group, the CF Foundation, and all the PROMISE participants and their families. So, thank you.
Thank you so much. That was very interesting. Do we have any questions? We do have a few minutes.
I'll ask very loud, sorry. Mitch Ramsey from Ohio State, really interesting study. And it's obvious that you have a real wealth of data and can look at it in a number of different populations, looking at a bunch of different outcomes. Coming from a pancreas perspective, I wonder, is there any way to look at sort of the pancreas function and some of the fatty acid metabolites in terms of what's kind of spilling over into the stool, and how does that affect some of these other metabolites that you've mentioned?
Yeah, no, that would be really interesting. I mean, I know we have data from PROMISE, like pancreas function. I just don't, in terms of meaning directly correlating it with these individuals. We haven't looked at that but we have like the elastase and everything for these individuals, so that might be an interesting, correlate to look at.
Hi, Nicole. Great talk. This is Alvin Chan, PhD from UCLA. I study bile acids, so my question is going to be tailored towards your DCA data. I think that you had showed that the DCA was decreased in the advanced liver disease patients who are on ETI. I wonder, I guess one way that maybe I can rationalize that is DCA is known to cause mucin depletion. It can cause, leaky gut, at least in animal models. So I'm wondering that maybe a potential mechanism might be those who do not, or that do have liver disease. Maybe the DCA can be causing some mucin depletion, causing the leaky gut, leading to something with advanced liver disease. I guess in humans, is there a way to look at mucin production to kind of further delineate that part?
Oh, that's a great question. Definitely very interesting thoughts, and I'd love to explore that more. I don't personally know any way that I'm aware of in looking at mucin production within this study for these humans, but
I guess I don't know what's collected, but I wonder sometimes if we do like endoscopies for any other reason, if there's ever
these individuals didn't get endoscopy, but yeah, it'd be something worth looking at. Thank you.
Thank you so much. Next, I'd like to welcome Dr. Ian Stewart. He is an advanced research fellow at the Imperial College in London, England. He will be discussing his abstract on multivariate classification of gut symptoms in people with CF, identifying 4 phenotypes. Welcome, Dr. Ian Stewart.
Good morning. Thanks very much for inviting me. So I'm a biostatistician and an advanced research fellow, and I'm hopefully going to convince you today that we've identified 4 major phenotypes of gut symptoms within people with cystic fibrosis. So I don't have any disclosures related to this talk, but just to say that the work was funded by the Cystic Fibrosis Trust. And so we've had a lot of talks, I think, over the past day or so about the involvement of gastrointestinal symptoms and dysbiosis, disorders, and dysmotility. And it continues to be a real problem for the CF community. So in the 2022 James Lind Alliance Priority Research Setting Partnership, the top three research priorities was still involved research to relieve gastrointestinal symptoms. And even, in the posters that you can see downstairs from the Cystic Fibrosis Foundation, the 24 strategic survey shows that these problems are still a huge issue for people in the post-ETI era. We also have looked at the prevalences of symptoms across a number of studies. So this was a rapid review on the left-hand side that just shows the amount of people that are reporting different symptoms across a number of studies that have been synthesized. And we've now taken this one step further to do a multivariate meta-analysis, which is basically a nice way of taking all this variability that you see on the left-hand side and putting some confidence intervals either side of it. And we've adjusted these plots that you see on the right-hand side for the region in which the people were living in at the same time. So, the global region. So you can see that, one of the highest symptoms is reported is flatulence. We have almost 50% of people reporting abdominal pain, a third of people reporting constipation. And what I find really interesting is, as we can all see that this is a huge problem, but we see that the confidence intervals are wide, right? There's an awful lot of variability. And as a biostatistician and a researcher, I'm interested in the mechanisms that explain that variability. Why do we have it? And I think it's fair to say that these symptoms aren't mutually exclusive. Some people have both or several symptoms. Some people might only report one of these symptoms. So although we can talk on a scale of how many symptoms someone has and how bad that problem is, what I'm interested in is understanding whether there are groups of people that are represented by, a collection of certain symptoms. And I think until we get to that point of understanding why some people have some symptoms and some people have others, we're not really going to be able to address the mechanisms behind these things. So, that's what we wanted to start to address. And the approach that we took was that we brought together a number of people within the field for a strategic research centre funded by the Cystic Fibrosis Trust. And this is really an interdisciplinary network, and it also doubles up as my acknowledgement slide. So this is our GRAMPUS Strategic Research Centre. It's to understand and advance the mechanistic and personalised understanding of symptoms in cystic fibrosis. We brought together gastroenterologists, radiologists, people who are experts in the inflammasome and inflammatory and work. We have people who understand microbiomics, metabolomics. We have statisticians, we have professors in clinical delivery, we have nutritionists. So we really have a huge wealth of expertise that we brought together in our interdisciplinary network across a number of different sites in order to start to understand why do people have different symptoms and what can we understand about the mechanisms to those. So our design involved a number of hypotheses that we wanted to address first and foremost. So our first hypothesis was that there are distinct phenotypes of gut symptoms that we can define using questionnaires. So in order to do this, we developed the GRAMPUS study from the network, where we have 300 people who have provided answers to a number of different questionnaires on their symptoms. Within this large group, we also have nested subgroups. So about 100 of them have had blood samples taken, and about the same number were supposed to have fecal samples, although not many people wanted to provide that in the end. And then within that nested subgroup, we have another nested subgroup of people who undertook MRIs. And so this was quite a long protocol of an MRI during fasting and also postprandial after being fed. So we have quite a granular amount of information within certain subgroups, but overall a large amount of information about their clinical history, their genetics. We have diet recall in these people, and we have a number of different symptom questionnaires. And then we have to also take that at 6 months and 12 months to really create a big picture to understand how symptoms may change over time and what the different mechanisms might be underlying it. And those nested subgroups also allow us to address the second hypothesis, which will be that any phenotypes that we can distinguish might be characterized by inflammatory markers, the gut microbiome, and the MRI physiology. So to address our first hypothesis, the approach we took is something called latent class analysis. So this is multivariate. It only uses the data that we receive, and we use it in order to distinguish phenotypes. So basically, people provide a lot of information, and it works on the assumption of probability in terms of people will group together based on the way that they respond to these different questions. So we have lots of questions going into it, and the LCA will provide a number of classes at the other end that we can investigate. So this is all about the input. What are we going to put into that latent class analysis? And I've tried to offset this slide of a big wall of poo with a nice poo emoji, so you don't have to look at all the different types of poo. But it's really important because basically the information that we're putting into the LCA is questions about their bowel habits. So we have 3 different questionnaires. We have the gastrointestinal symptom rating score. This includes 15 different items, which includes things like pain and bloating and flatulence. These are scored on a Likert scale of 1 to 7, from no discomfort to severe discomfort. We also have PAC-SIM, which is the patient assessment of constipation symptoms. These are 12 items: pain, bloating, cramp again. These are on a Likert scale of 1 to 5, absent to very severe. And then we also included a number of questions that weren't really being captured by GSRS and PAC-SIM, which we call the GRAMPUS-7 within our cohort. And so these include things like frequency, how many times people are going to the toilet, the Bristol stool chart, which is what you can see here, and then also information about the sort of texture and consistency of the poo, and how much it interferes with people's quality of life. And what I wanted to kind of highlight as well is that we ask these questions about how often people go to the toilet and what it's like, but these aren't sort of questions with always a right answer and a wrong answer. And so what we really needed to understand is, can we create a unidirectional way of addressing this? Can we go that sometimes going to the toilet a lot is just as bad as going to the toilet not very often? Similarly, having type 1 is as bad as having type 7. And so we really had to sort of break these items apart in order to get the meaning from them. So in the end, what we had was 36 indicators. They were all unidirectional, which meant that it was always in the direction of sort of never or absent to often or very severe, and in this ordinal way. So this is some work done by my PhD student, Jamila, where we're trying to understand the optimal number of classes that came out of that latent class analysis. So we ask it to give us 1 class, 2 class, 3 class, all the way up to 6 classes. and we look to see how optimized the model is with those. So what we're really looking for on the left-hand side, the top left, AIC, is the lowest point on that plot. That will tell us the best number of classes. In the middle one, again, we're looking for the lowest point. And as you can see on both of those, we've got kind of 3 or 4 classes as being reasonably optimal. It's a kind of art doing this kind of classification. There's no definitive right number of classes. You kind of have to work out what makes the most sense. So we're looking at 3 or 4, and then on the right-hand side, top right, we have entropy. So what we want is a really high entropy because it means that our classes are stable. It means that every time we run the model, people aren't going to shift between classes. But we don't want the entropy to be too high because we don't want it to just overfit the data and be relevant to our population and to no other populations. So we're really looking for a kind of 0.9 on the entropy scale here to make sure that we've got a good balance. And so I think based on the AIC, the BIC, and the entropy, we went for 4 clusters as being our optimum. And on the left, you can see what the model spits out is class A, class B, class C, class D. It doesn't give them any labels. It doesn't care what goes into it. It just provides some classes. And you can see that we have about just over a third of people within class A, another third of people within class B. We have 20% of people in class C and just over 10% of people in class D. And again, we want the share to be at least 10% or over, because anything below 10%, we're starting to get into that area of unreliable. Maybe it's only our data that has this 10%. So we really want a reasonable representation. And then if we look at the age and the sex distribution, you can see that it's reasonably well represented across A, B, C, and D. What we don't want is, class A to just be all the old people and class D to be all the young people. You can see that everyone's kind of around 30 years old on average, and we have around about 60% of males in most of the classes, except for class D, where it's a little bit less. But overall, we have 4 classes, and they're reasonably well represented. As I said, the model doesn't care what the classes are. We have to provide some sort of human interpretation of how to label those classes. And so this is where we look at the probability. Depending on how someone scored on a particular question, we're interested in the probability of being in a certain class. So what you can see on the top left and the top right is the probability of being in class, in one of the classes versus another class if you've scored 2. You can see that the quality of life, if you score 2 or 3, is giving you a low probability of being in this class. So it basically means that people are generally saying that their quality of life is okay if they're in that class on the left. So we called it mild. Whereas on the right-hand side, people are likely to be in this class if they're scoring 2 or 3 on quality of life. So we generally call this severe. This is a kind of reductionist approach, a kind of oversimplification, but the point is we have to give it labels to understand its meaning. So we have a mild class and we have a severe class. But that's 2 of the 4 that I said that there were. So there are 2 others to look at. So this is the probability of being in the other 2. And what we now see is that if you score 2 or more, your probability of being on the left-hand side is quite high if you report infrequent or hard, which basically means that we gave this the label of moderate, but predominantly constipation. And on the right-hand side, we had people who were more likely to be in this class if they were scoring high on frequency and loose stools. So we gave this a moderate and called it predominant. Now, this is just 9 of the 36 indicators, that we're looking at across here, just to kind of simplify things. But if I was to put this across all of the different indicators that we used, what you can see is that we have, you can name your favorite symptom or whatever, and we can look across this radar plot to see how the people within those classes respond on those symptoms. And it really nicely actually distinguishes out kind of the severe from the mild, and then the 2 moderate groups in a constipation and diarrhea items. And what's important, I think, for me as well is you know, we can all say some people's symptoms are worse than others, right? But what we see here in the multivariate analysis compared to something like the PROM scores is that the GSRS overall, it kind of identifies our severe group, but everyone who isn't severe is just kind of below 2. They're all kind of the same. And the same kind of thing happens for PACSIM overall. It's really good at finding the severe people, but everyone else is just as you know, the same as mild, right? And within GSRS, and we also have domains of constipation and diarrhea. And again, what you see in here is that it's really good at finding our severe group, but it's not so good at distinguishing people who were reporting quite highly on constipation and diarrhea items. They still seem like the milds. So what's important about the multivariate analysis is that we're actually now able to discriminate these kind of phenotypes as well as the severity. And I think that's an important step to be taking. And now that we have the classes, what we can begin to do is look at the relationships within them. So on the left-hand side, this is work from Darren Sills, where he's looking at the dietary components. And it's, you know, just as a heat map to demonstrate that there are very different nutrient constituents in the people who are reporting within the severe classification compared to those in the mild and the moderate. I think you can reasonably distinguish that there's something different going on between those people. And that's also just to remind you that the people within that severe group are reporting severity of diarrhea and severity of constipation. It's not one or the other. They feel both those things. And I think, again, it's important for us to recognize that it's not one or the other. And so these are the diets that involved with those. We can see that fecal calprotectin is reasonably similar across all of the classes, although there's perhaps something going on with the moderate groups, and maybe this is an unmet need within those groups compared to the severe and the mild groups. And if we look at the microbiota that we've preliminary got at the moment, we can see that actually the severe group and the moderate constipation group are significantly different, as well as the mild group from the severe group. So there is, again, some differences in similarity index in the microbiome compared between these different classes that we need to investigate a little bit more. So the future work is really to integrate all this information together. So we have in these people, we have their blood proteomics, we have fecal inflammatory cytokines, we have fecal calprotectin, we have immune cell subsets from the blood, we have microbiomics, lipidomics, proteomics, metabolomics, we have all the genetic data, the nutrient data, we have MRI metrics. We really want to start layering all this together to understand what the mechanism is to be in one class versus another, and to address our third hypothesis of integrating the data to identify personalized management. And so in conclusion, we know that GI symptoms are common in CF even in the post-ETI era. We've got 300 questionnaires using 36 symptom indicators. There were 4 major phenotypes. These were mild, moderate constipation and moderate diarrhea, and severe. And our early analysis suggests that there are different characteristics within these classes, including the nutrition. And we are now going to use integrative analysis to explore the mechanisms behind them. So thank you very much.
We have time for some questions. Anyone have any questions?
Hi, how are you? My name is Rosara Bass. I'm a gastroenterologist at Nationwide Children's Hospital. I was wondering if you could go back to that diet slide. What were the diet components that were different in the severe group?
So there's probably a lot more to look into this, and one of my colleagues will look into it as well in terms of the patterns and the quality of diet. One of the things that seems to be different is the red represents lower. So these guys generally have a sort of lower nutritional content of everything that they seem to be taking in. And that includes sugars and things like that. We don't necessarily know what the pathway here is, whether this is just correlated because, you know, these people have a severe diet and so they're being more mindful about what they're eating to not exacerbate it, or whether the things that they're eating are causing them to be in classes. But a lot of it is to do with the sugars and different sugars that they're taking versus other groups.
And was their total caloric intake lower as well?
So this is, I'll double check that, but this is adjusted for caloric intake just to make sure that, yeah.
Thank you.
Thank you.
Hi, Jay Freeman, same place she's from. The categorization of constipation and diarrhea, it bothers me a little bit. We can have severe constipation show up as diarrhea with overflow, but more importantly, when we did the Galaxy study, what was interesting to me is if we asked patients if they had hard stools, if they had constipation, our reports for constipation were only about 25-30%. When we started getting into pelvic floor dyssynergy and asking about straining, incomplete evacuation, that was the part that this was only up for a little bit, but I didn't see a lot of that pelvic floor issues that really drives what we think of about in constipation for our older patients. So how are you guys addressing that and using that in this? And if it's in that circle somewhere and I missed it, I apologize.
Yes, so I mean there are things within the PAC-SIM in terms of incomplete, painful bowel movements, discomfort, cramp. I mean, we are only using the items that are reported within the questionnaires. We're not using the items overall as a score. We are breaking them down into the indicators. And my oversimplification of the classes is simply to kind of confer an interpretation. But obviously, there's much more detail in terms of being, you know, what the other items and probabilities are within those individual classes. But you know, within, I think what's interesting is what you say isn't necessarily different to what we've found. You know, there are people, 10% of people are in that severe group, and they report high on all of it. You know, on diarrhea and constipation and painful movements and all these different things. And then within the other groups, the moderate constipation, they're much more focused on the items that are more related to just constipation without that diarrhea side of things. So I think this multivariate approach is discriminating those sorts of distinctions that you guys have found as well.
Well, and I hesitated to say anything because I know Alan's going to give the talk with the clinical part, so maybe I'm jumping the gun here a little bit. But, you know, we use PAC-SIM, PAC-ESIM, PAC-QL in ours, and we still, when we asked these questions in the PRO, we didn't get the answers that we got when we asked specifically about some of these other pelvic floor dyssynergy symptoms. So just something to think about, because I have to assume the idea of this is to get a therapy at some point, which again, I think Alan's going to talk about. But if you don't characterize the type of constipation, the type of diarrhea, it's going to limit your ability to move forward clinically. So that's all I'll say, and I'll allow Alan to go.
Thank you, Dr. Stewart.
Thank you.
Our next speaker is a professor of child health and dean of School of Medicine, Dentistry and Biomedical Sciences at Queen's University, Belfast in Northern Ireland. He's here to discuss his work on gut research, advancing a mechanistic and personalized understanding of symptoms in CF, or GRAMPUS-CF, clinical manifestations. Please welcome Dr. Alan Smith.
Thanks very much for that introduction, and thank you to Ian for explaining the statistical analysis so that I don't have to. I'm particularly pleased with the acronym, Gut Research Advancing a Mechanistic and Personalized Understanding of Symptoms in CF, or GRAMPUS. It took me a long time to think of that. I'm going to walk through a little bit of the backstory to the GRAMPUS study, and then talk about some of the clinical correlates of the latent classes that we've identified. I have put some QR codes in the talk as well, and that will lead you to our more about our study and some of the papers that we've published. These are my disclosures. And I think Ian has touched on this already. So I'm a pediatric pulmonologist, and I'm intruding into the world of pediatric gastroenterology. And the reason I'm doing that is because the patient community have told us that gastrointestinal symptoms are important to them. And we did 2 exercises to find this out. The first was before ETI became widely available, and this work was done through the James Lind Alliance. And it involves bringing the patient community and the clinical community together to decide what should be the top 10 questions for clinical research in CF. And you can see on the left-hand side the work we did in 2018. And then after the arrival of CFTR modulators, we repeated the exercise in 2022. And this is representative, so 1,600 people contributed to the list on the right-hand side from 29 different countries, including the US. And gastrointestinal symptoms and the importance of research in relieving those symptoms was in the top 3 on both occasions, so didn't really seem to have been affected by modulators. And we know from conversations with patients and families that gastrointestinal symptoms are experienced by most people with CF: bloating, flatulence, abdominal pain. Our work has shown that 2/3 of adults with CF will miss work and 2/3 of children will miss school because of gastrointestinal symptoms. So clearly these are intrusive and frequent daily symptoms. But of course, the problems our patients experience with gut symptoms are not confined to intrusive symptoms, but also involve complications. The most important being distal intestinal obstruction syndrome, or DIOS. And to illustrate this slide, I've gone right back to the early 60s, and this is a case series of DIOS. It includes some really helpful surgical drawings from patients who went to theater. And I was struck by this description of a firm, adherent, clay-like material filling the cecal cap, extending across the ileocecal valve into the terminal ileum, and histology showing streamers of mucus starting in the mucus glands and extending into the lumen. So it's easy to see from these early visualizations how obstruction can occur, and the ileocecal valve is a natural pinch point. The plain abdominal x-ray is one of our patients with CF who had to go to theater for an episode of severe DIOS. So we've formulated a hypothesis about what might underpin some of the GI symptoms and also GI complications in CF. And our hypothesis is that there's dysmotility, and that stool does not proceed, or rather ileal content does not proceed through the ileocecal valve. Ileal content should be liquid, and instead there is dysmotility. This in turn leads to dysbiosis and something that we've termed fecalization. So the liquid ileal content becomes much more solid. This in turn, we think, may invoke inflammation of the gut wall and narrow the lumen. So we designed a series of studies which we called GIFT, I've forgotten what the acronym stands for. Gut Imaging for Function and Transit, or GIFT. And we did a series of studies, the first being a comparison of 12 people with CF with 12 controls. And I'm going to walk you through the MRI protocol that we use because it's also part of GRAMPUS. So patients, this is intensive. Patients come fasted. They have an initial MRI. You can see the MRI set up on the far left with an abdominal receiver coil. They then have a measured meal, which is high in fat. And basically, over the next 6 hours, we follow that meal all the way from the mouth to the cecum, and we measure something called orocecal transit time. And if you remember those pictures I showed a moment ago, the pinch point, we think, is at the ileocecal valve. So the time it takes to get to the cecum will be dependent on any narrowing which occurs there. We're also able to measure a number of other things, including the amount of liquid ileal content and liquid small bowel content, which we call small bowel water, and we can measure the volume of the colon as well. And what we found when we compared 12 people with CF with 12 controls is that orocecal transit is very different in CF. The average duration was 330 minutes versus 210 minutes in the healthy controls, so about a 2-hour time difference. We found that there was more liquid in the lumen of the small intestine at every time point over a 6-hour period. So on that graph, the upper line are the individuals with CF. And what we hypothesize is that there is narrowing at the ileocecal valve and that fluid backs up behind that narrowing. The narrowing accounts for the longer orocecal transit, but the backup is a bit like traffic on a motorway backing up behind an obstruction. I think I can show you what we look for. So the video shows you the ileal content passing from the terminal ileum across the ileocecal valve into the cecum. And this is the point that we say that orocecal transit is complete. We've also gone on to do some other things. This is the work of Neela Delshaft. So in the red circled areas of small bowel, she's highlighted small bowel content. On the left, you've got controls. On the right, you've got people with CF. The appearance of the small bowel content is uniformly gray in individual controls, as shown by the white arrow. And it is this stippled white appearance in individuals with CF. And this is what we call fecalization. So the appearance in CF is much more what you would expect to find in the colon, not in the ileum. And we think this may help us understand our hypothesis. We also found that the motility in CF was about half what we expected in controls in the small bowel measured with MRI. And Ian's mentioned the work of our colleagues in Northumbria University who are doing the microbiota work. They found that, unsurprisingly, there was significantly less diversity in the CF group. But also, if you look at the satellite taxa, so the less common organisms, the diversity was related to MRI metrics such as orocecal transit and small bowel water. So having demonstrated differences between people with CF and controls, the obvious thing was to say, okay, well, when you give a modulator, does any of this change? And this was prior to triple modulator therapy. So the modulator available was Tezacaftor-Ivacaftor. And we designed a crossover study where we gave treatment A for 28 days, 28-day washout, 28 days of treatment B. And we did this in a dozen patients with an MRI done at the end of each of those 3 periods. And we also measured the stool microbiota, and we found that for Simcavi, at least, Tezacaftor-Ivacaftor, there was absolutely no effect of the modulator on MRI metrics or indeed the microbiota. And that might be because we didn't treat for long enough, or we used the wrong modulator, or possibly modulators don't have a profound effect on the gut. But this study really didn't, as a negative, didn't advance us much further. Very close on the heels of that came ETI. ETI in the UK was licensed and funded at the same time, so there wasn't the opportunity to do a controlled study. So we did a cohort study with 24 participants who had an MRI scan before starting ETI and had stool collected for microbiota. And then we followed them up for 3 months, 6 months, and 18 months. And what was interesting here was that we didn't really see a shift in the MRI metrics until 18 months had elapsed. And then we saw a change in orocecal transit from a baseline of over 360 minutes to 18 months of ETI. We found orocecal transit was about 240 minutes, so a 2-hour difference again. And the CF patients developing orocecal transit, which was much more in keeping with what we'd seen in healthy individuals. We were slightly perplexed by what happened to small bowel water. We thought, well, if transit's increased and flow is better and there's less obstruction, small bowel water should diminish. It, in fact, increased. And we hypothesized that that's because CFTR is present in abundance in the small bowel mucosa and it's being switched on by ETI, and the increased production of fluid outweighs the increased flow. And interestingly, we saw a reduction in colonic volume, which is in keeping with less constipation. So on to GRAMPUS. It's all very well being able to show differences in physiological measurements between individuals as measured with MRI. But I don't have patients coming into my clinic saying, you know, I'm not feeling so good because my orocecal transit is considerably prolonged. And the key thing we wanted to do was to see, does this matter to how an individual feels or functions? Do these physiological measurements tell us about how an individual feels or functions? So with GRAMPUS, we designed things the other way around. We started off with, as Ian has described, with 300 participants completing a questionnaire. Then in a subgroup of about 100 of those, we've collected blood and stool for inflammatory mediators and microbiome. And in about 30 of those, we've done MRI studies. And we're just beginning to get the data from those now. So I'll tell you a little bit about some of that information. We also have very detailed clinical data for each of the participants. And there is, as you can see in the kind of orange color there, there's a pediatric subgroup, which will give us some additional information about children. So a little bit about the baseline characteristics of these individuals. I'm just going to walk through some of the important points here. The gender difference was roughly what you would expect. We were talking about patients in their early 30s, by and large, the median age, a BMI of 23.5 median, and FEV1 76%. 80% on ETI and 4% on another modulator. The proportions homozygous for delta F508 and heterozygous were what you would expect from the UK population. About 14% had a history of meconium ileus, 21% a history of DOS. There was around a third with CF liver disease, 38% with CF-related diabetes, and almost half with gastroesophageal reflux. 85%, again, as you would expect, were taking pancreatic enzyme supplements. And interestingly, about 60% on long-term oral antibiotics, primarily azithromycin. This is the radar plot that you've seen, and as Ian has told us, we've demonstrated that 36% fall into the mild group, 33% into the constipation predominant moderate group, 19% into the diarrhea predominant moderate group, and 12% into the severe group. And I think what the radar plot shows is that for some symptoms, so for example, vomiting, the phenotypes don't divide patients at all. That might be because vomiting is not a prominent or important symptom in most people with CF most of the time. But if you take a symptom like bloating, that the phenotypes do divide out the groups considerably. So I'm going to tell you now about how the latent classes relate to complications. And it's important to know that the latent classes are derived from 36 questionnaire questions. So they don't take into account other information such as the patient's medical history, though we do have access to that information from their medical records. And I think it's probably worth a shout out here to the fantastic collaboration that we have had as part of the GRAMPUS project. So Daniel Peckham is in the audience, and Leeds have made a tremendous contribution to this in contributing patients. Helen Barr from Nottingham, Damien Downey from Belfast, and this is a huge team effort. But what you've got here are forest plots. What we're doing is we're describing the severe, moderate diarrhea and moderate constipation groups, how they relate, their risk of having a complication relates to the mild group. So the mild group is the comparator in each case. And I've indicated with a red arrow those which are significantly different. So for the moderate group, both with constipation and diarrhea, there's a significant association with CF liver disease. For the severe group, the association is with gastroesophageal reflux and distal intestinal obstruction syndrome. Then looking at concurrent medications, the severe group were more likely to be prescribed a proton pump inhibitor or to be prescribed laxatives. Again, not surprising, but this seems to validate the phenotypes which we have derived from those 36 questionnaire questions. The moderate with constipation and the moderate with diarrhea have got a slightly perplexing and puzzling relationship with less use of long-term antibiotics. And that's a piece of information we'll have to take away and think about. And I think some of the mechanistic data that we have for each phenotype will help us, I hope, unpack that. And then finally, Ian touched on this, but Darren Sills, our dietitian, has been doing some superb work on the diet. We collected dietary information using Intake 24, which tells you in really granular detail what the patient has had to eat in the 24 hours before they complete the abdominal symptom GI questionnaires. And what you see on this simplified heat map is two dietary pattern measures. There's the diet quality index and the diet inflammatory index. And it took me a little while to get my head around the dietary inflammatory index. But for example, we know that turmeric is believed to be anti-inflammatory, and that contributes minus 0.7 to the dietary inflammatory index. Trans fats, which we think of as bad, contribute a plus 0.2 to the dietary inflammatory index. And what you can see is that the severe group have a relatively poor diet and a relatively inflammatory diet, but some intriguing signals here as well. So moderate with diarrhea seem to have the worst diet quality of all. And as Ian has mentioned, it's hard to be sure if that's a compensation to symptoms or whether there could be a causative pathway. So just to wrap up, our latent class analysis of a large representative sample of adult CF patients based solely on gut questionnaire responses has given us 3 symptom phenotypes. I think the validity of the latent class analysis is supported by the association with CF gut complications and concurrent medications. So the severe phenotype associating with reflux, with DOS, with PPIs, and with laxatives. The moderate group association with liver disease, I think, and reduced antibiotic usage is perplexing, and we'll need to take that away and think about it and use our other mechanistic tools to understand it. We're currently analyzing the microbiota, the inflammatory mediators, and the MRI metrics. And one thing that we're really interested in is the stability over time. So we have the questionnaire data at baseline 6 months and 12 months. So if you start off in the severe category, are you still in the severe category at 6 months and 12 months? And that will be an important piece of work. So thank you all for listening. I have to thank the funders of this, the CF Trust, who've been absolutely fantastic. This is the work of a large team. This is us getting together in Belfast. Of clinicians and scientists and early career researchers. It's incredibly exciting to work with these guys. I need to call out Katie, our patient representative, who keeps us grounded and keeps us focused. And again, thank our funders, the UKCF Trust, for their contribution. I'm very happy to take any questions.
Anyone have any questions?
Steve Friedman from Harvard. That was great. You know, I guess my question is ultimately, how is that informing treatment? And I know this is important work. And, you know, are you taking, maybe along that line, taking into account response to therapies? Because obviously we're not just watching people, but response to laxatives, response to prokinetics that may tell us about mechanisms. And importantly, that group that doesn't respond, you know, what is it that's different about them that maybe we could predict up front and not waste our time with meds that don't work?
That's a really important question. I guess one of the things that frustrates me, first of all, is the assumption that everybody with GI symptoms has got the same pathology and is manifesting something similar. They're not, because clearly some have constipation predominant, some have diarrhea, and perhaps some parallels there with irritable bowel syndrome. The other thing that frustrates me is we take things that work in another context and we apply them to CF in the hope that they'll work, but not based on an understanding of the mechanism. So these are preliminary findings, Steve, and what we hope to do is unpack the mechanisms. You know, it might be that what arises from this is a study of dietary modifications. I think probably the time is right for that, because the high-fat, high-calorie diet we've promoted for decades is probably outmoded now. But could we make those dietary modifications in the light of understanding how much inflammation contributes and how much dysmotility contributes, etc.?
Hello, thank you for this. This was really awesome data to see. I'm Chris, I'm the dietitian from UW. And one question I had was for your patients whom you assessed MRI transit time, oral ileal transit time. Did you guys give them any questionnaires about symptoms, whether they were struggling with early satiety or bloating symptoms? And did you draw any correlations between those who had higher transit times and their symptoms?
No, that's a really good question. So our questionnaires for GRAMPUS have been the GSRS and PAC-SIM. And we felt those were validated not specifically for CF, so we introduced a few questions about CF, particularly around steatorrhea and the Bristol stool chart. I would have to go back, honestly, and check if we'd asked about early satiety, because that's a really important point. Simplistically, in my head, I would link prolonged orophyseal transit and increased small bowel water with, problems of obstruction and symptoms of bloating. And bloating seems, if you listen to patients, bloating is a symptom that I think physicians don't really understand intuitively, but patients know what it means and they frequently report it.
We had an excellent talk on bloating yesterday. Thank you for everybody who did that too.
Hi, I'm Kelly Stewart from University of Utah with the adult team. Wonderful talk, and the previous talk as well. I'm curious if you have any brainstorming, thinking when you said that the severe phenotype is associated with the GERD, DOs, PPIs, and laxatives. Something we debate a lot in our clinic is chicken or the egg. Are these PPIs contributing to more gut symptoms, or people with more gut symptoms really needing PPIs? Have we contributed to the problem by prescribing a lot of these? I'm just curious what some of your thoughts are. I know you don't have definitive data yet, but looking at all of this and thinking about it, what are your initial thoughts?
That's a really good point. And I suppose, in fairness, PPI use is something that has at least been informed by an understanding of the mechanism. So, there's insufficient bicarbonate production in the small bowel. Therefore, neutralizing gastric acid with PPI should help. But there aren't, as far as I'm aware, good studies showing that the use of a PPI objectively improves, reduces malabsorption, improves absorption, or reduces symptoms. So I think we want to dig into that a bit more deeply. These are really the first findings. We have very detailed clinical data on the patients as well. And we have the luxury of being able to see what happens at 6 months and 12 months.
Well, I'll be looking for that. And I have to note also clinically, I find something similar. My patients with the most severe gut symptoms have very limited diets. And I think part of it is psychological. They are so dismayed by their gut symptoms. They don't want to eat. They wait until the last minute to eat because they're dreading the gut symptoms. And then they are overcome by understandable hunger and they make really poor choices. So it's really can get into this cyclical cycle. So thank you.
Thank you, Dr. Smith. Our next speaker is Dr. Jennifer DeYoung, Assistant Professor at UCSF Binnenhof Children's in Oakland, California. She is here to discuss her work on fecal microbiota changes in people with CF after 6 months of ETI, findings from the PROMISE study.
Hi, thank you for the introduction, and thank you all for joining me today. As mentioned, my name is Dr. Jennifer DeYoung. I'm a pediatric gastroenterologist at UCSF, and I'm really excited to share my research talk with you all today, which is entitled Changes in the Fecal Microbiota in Patients with CF with 6 months of ETI. These are the findings from the PROMISE study. I have no relationships to disclose related to this presentation. As a gastroenterologist, I'm interested in the GI manifestations of CF, which contributes to significant morbidity and mortality. These manifestations can be divided into 3 categories, including pancreatic disease, luminal disease, and hepatobiliary. We know from prior work that fecal dysbiosis, or an imbalance in the gut microbiota, is present in patients with CF, and compared to those without CF, patients with CF have a decrease in their microbial diversity, an increase in the firmicutes to Bacteroides ratio, a decrease in Bacteroides, a higher abundance of pro-inflammatory microbiota, including Enterobacteriaceae, Streptococcus, Veillonella, and Staphylococcus, as well as a relative depletion of beneficial microbiota, including Bifidobacterium, Clostridium, and Akkermansia. The reason for this dysbiosis isn't entirely clear, but it's thought that there are permutations in the CF GI tract that select for altered microbiota, including thickened mucus, abnormal intestinal pH, slowed intestinal motility, alterations in immune function, and this is further exacerbated in the setting of frequent antibiotic exposure, high-fat diet, as well as acid suppression use. And it's thought that the dysbiosis may contribute to both gastrointestinal as well as extraintestinal manifestations. For the purpose of this discussion today, we'll be focusing on intestinal inflammation, which is often measured with fecal calprotectin. We know that CFTR modulators are powerful new therapies, and it's really exciting to study this research project in the setting of these modulators. Particularly ETI is approved for patients 2 and older with greater than 1 F508 del mutation. And we know based on the PROMISE and RECOVER studies that ETI has been associated with a decrease in calprotectin. However, what we don't know is how the fecal microbiota relate to calprotectin following ETI. And so the purpose of this research has been to explore the link between inflammation, fecal dysbiosis in the setting of correcting CFTR dysfunction with ETI. We hypothesized that the microbiota would differ between subjects with high versus low calprotectin, and that restoring CFTR function with ETI would decrease the abundances of pro-inflammatory bacteria relative to pretreatment, and that would correlate with a decrease in calprotectin. We are utilizing samples from the PROMISE study, which again is a prospective multi-center observational study measuring the effectiveness of ETI, and specifically we're looking at patients 12 years and older. Again, multiple organ systems are being studied as part of PROMISE, but for today I'll be focusing on GI health and intestinal inflammation. For our study design, fecal samples were collected from subjects before and after initiation of ETI over a 2-year ongoing period, and measurements at each time point included the microbiota as well as calprotectin. Our analysis includes 345 samples from 124 subjects, but it's important to remember that we have additional time points pending collection. For our methods, fecal calprotectin was defined via the ELISA immunoassay, and the microbiota was defined via shotgun metagenomic sequencing. For our baseline characteristics, again, we have 124 subjects we analyzed, the majority of which were male, with a median age of 22 years and of white race. Most of these patients were heterozygous for F508, pancreatic insufficient, and most have been on prior modulators. Because medications can also affect the gut microbiota, we were also interested in the use of the most common medications over the 6 months of ETI. Looking at ursodiol, inhaled antibiotics, and oral azithromycin, we found no significant differences among usage of these medications in the 3 visits. We found there was a statistically increased use of acute antibiotics at 1 month post-ETI as compared to pre-ETI and 6 months post. And we were also interested in laxative as well as acid suppression use, which was collected at baseline, but unfortunately not during the study course, and therefore was not included in this analysis. So moving on to our results, consistent with prior studies, we did see a significant decline in fecal calprotectin at 1 and 6 months post-ETI, such that the majority of patients fell within the normal range of less than 50 fecal calprotectin after ETI. We were then interested in looking at our first hypothesis to see if there would be differences in the fecal microbiota, comparing those with high versus those with low calprotectin. Shown here is a principal coordinates analysis, which is a graphical representation of community-level characteristics of the microbiota. So individual circles represent individual microbiotas, whereas the larger circles represent the average. And the larger ellipses represent clustering of fecal calprotectin, with teal indicating normal, orange indicating borderline calprotectin, and purple indicating abnormal calprotectin. And what you can see here is that we detected significant differences in those with abnormal calprotectin as compared to those with normal calprotectin. We were then interested in characterizing the bacterial species that significantly contributed to calprotectin. And we did this using random forest modeling. So here is a random forest plot. And along the x-axis are the species and random forest importance score along the y-axis. And some notable species I wanted to highlight from this plot is Staphylococcus aureus having the highest random forest importance score. And other highlighted species include those within Enterobacteriaceae. We also performed Spearman correlation and found that the model performance improved with the addition of more species, ultimately saturating at 20 species as indicated by the red dotted line. We were then curious to see what changes would be present in the microbiota following the initiation of ETI. So again, another principal coordinates analysis. This time the teal represents pre-ETI, the orange represents 1 month post, and the purple represents 6 months post. And what you can see is that there are differences in the microbiota at 6 months of ETI as compared to pre-ETI and 1 month post-ETI. We were then interested in looking at those top 20 species significantly associated with calprotectin, and we found that there was a significant decline in the relative abundance of 7 of those 20 bacterial species after ETI. So shown here is a box plot with time points along the x-axis and relative abundance along the y-axis. This is shown for Staphylococcus aureus. And as you can see, there is a significant decline in relative abundances at 1 month and 6 months post-ETI. A significant decline was also seen for Clostridium scindens, Anaeroglobus geminatus, Enterocloster clostridioformis, Escherichia coli, Clostridium butyricum, as well as Ruminococcus navis. And all of these changes correlated with a decrease in fecal calprotectin. These results support a close relationship between intestinal inflammation and the microbiota in people with CF. We were also interested in seeing the percentage of samples with detectable levels of the following 3 species, and found that at 6 months post-ETI compared to pre-ETI, there was a significant decline in 3 species. So again, along the x-axis is our time points, and along the y-axis is the percentage of samples with detectable levels of the following species. And so for the samples with detectable levels of Staph aureus, you can see that there is a 50% decline by 6 months post-ETI, a 50% decline for samples with detectable level of Enterocloster clostridioformis, and a nearly 100% decline for samples with detectable levels of Anaeroglobus geminatus. So you can see that there's a marked decline in pro-inflammatory bacteria following ETI. And the notable thing is that this decline seems to be more pronounced at 6 months as compared to 1 month following ETI. So what are the implications for these organisms in human health? Well, of the 7, 5 have been found to be pathogenic, whereas 2 are considered commensal or beneficial organisms. The 3 asterisks are species in which detectable levels decreased following ETI. And so I'm going to go through each of these species. So for E. coli, it's been found that E. coli is increased in CF stool samples as compared to healthy controls. Staphylococcus aureus is the most common respiratory pathogen cultured from sputum from samples collected in PROMISE. Enterocluster clostridioiformis is found to be elevated in pro-inflammatory GI diseases, including irritable inflammatory bowel disease, or IBD. Rhumatococcus navis is also found to be elevated in IBD, as well as individuals with colorectal cancer. Anaeroglobus geminatus is found to be elevated in those with liver disease. And then as far as our two commensal organisms, which are both Clostridium species, Scindens is a secondary bile acid producing organism that's been linked to resistant and C. diff infections. And Clostridium butyricum is a producer of short-chain fatty acids, which is an important metabolite in promoting GI health. So in conclusion, we analyzed 345 samples from 124 subjects. 6 months following the initiation of ETI, we saw a significant decline in the relative abundance of 7 bacterial species, which correlated with a decline in calprotectin, 5 of which were pathogenic, and 2 were commensal, as well as producers of key anti-inflammatory bacterial metabolites, short-chain fatty acids, and secondary bile acids. We found that the relative abundance decline was more pronounced at 6 months as compared to 1 month post-ETI, which suggests that changes in the CF GI tract may require longer treatment as compared to other organs, such as the lung. Overall, our results suggest a strong relationship between CFTR function, intestinal inflammation, and the microbiota. Limitations of our study include a short treatment duration, lack of control for the effects of antibiotics, diet, as well as other treatment changes, the use of relative abundance rather than a combination of relative and absolute abundance, and as this is an observational study, we are unable to establish causal relationships. For more details, I invite you to read a recently published article within the Journal of Cystic Fibrosis highlighting our results. And then, of course, this is an evolving story, and we have lots of future directions, including measurement of the microbiota, as well as calprotectin at later time points, the fecal metabolome with a focus on bile acids, as well as short-chain fatty acids, and then correlation of all the above with other markers of GI health, including elastase, nutritional measures, as well as GI symptom scores. Lots of people I'd like to acknowledge, including the PROMISE study PIs, coordinators, patients, and families who are enrolled in the PROMISE study. The Hoffman Lab, especially Luke Hoffman, who's been my mentor throughout my fellowship and as I'm now a new faculty member. Members of the Hoffman Lab as well. Adrienne Verster, who is an amazing biostatistician. The Salaponte Lab, which has been helping us with sequencing. And then my pediatric GI and CF team at UCSF. Happy to take any questions.
That was an amazing talk. Thank you very much. My name's Paul from Case Western Reserve. I'm curious, so there's a decline in a lot of these, especially like staph or some of the more pathogenic. Since it's not completely eradicated, is there a chance, I'd love to see the, as times go out further, but what if a person with CF is no longer able to get modulator therapy? Is there any indication that removal of this might cause an exacerbation or a bloom on any of these?
That's a really interesting question. I think it's really challenging to know because we have very limited data on how the microbiome shifts with modulators. So it would be really interesting to see if these changes persist even as they're off modulators. But unfortunately, I don't have the answer for that right now, but that's a really great question.
Sure, thank you.
Tom Ziegler from Emory University. Great presentation and really good study. Couple questions. You mentioned you're doing shotgun metagenomics. Are there any, I know it's not the purpose of this talk, but are you going to look at gene functional pathways and see if ETI does anything with that? And that was one question. You may or may not be able to know that yet. But you mentioned sputum culture. Is there any correlation with gut microbiome in CF in this study or independent of this study, and changes in the microbiome of the lung?
Yeah, those are two really good questions. To answer your first question, we are going to be doing functional metagenomics. And so one area of interest of mine is in like the bile acids, especially since we saw a bacteria linked with secondary bile acids. So I think at some point we're going to be focusing on primary, secondary bile acids, as well as bile salt hydroxylase gene. So lots of interesting things coming out of this project. The second question was in regards to the link with sputum. And it's actually funny because one of my colleagues, I think, is presenting the respiratory sputum results from PROMISE, I think in the other room. But I think that would be the eventual goal, would be to kind of study the gut-lung axis in greater detail.
Great. Great presentation, Dan Leung from Houston. As we all know, antibiotics certainly confound the microbiome and can also contribute to dysbiosis. And I apologize if I missed this, but did you look at antibiotic usage during that specific period? And sort of counterintuitively, not that I'm concerned that added antibiotics resulted in the reduced burden of the pathogenic organisms, but perhaps may have reduction of antibiotics while they were on ETI have actually been associated with the changes that you saw?
Yeah, that's a great question. I do have a previous slide looking at medication use over the course of this study. And so the medications we did look for, because we know it has an effect on the microbiota, was ursodiol, inhaled antibiotics, oral antibiotics, acute antibiotics for pulmonary exacerbation, as well as laxative and acid suppression use. And so unfortunately, at every time point, medication information wasn't collected every time, but we didn't see a significant change in at least inhaled antibiotics and oral azithromycin, though we did see a slight increase at 1 month post-ETI for acute antibiotics, but that was only one patient. So I would argue that while it was statistically significant, I don't know if it was clinically significant. Overall, we are seeing a decrease in antibiotic use. So definitely, I think there are many confounders in the study. I think the other thing that makes this study a little challenging is that patients have been on previous modulators before, and so we also don't know what effect the prior modulators have had on the microbiota. So I think lots of questions, not a perfect study, but I think it just gives us a little bit more information.
Thank
you. We have a question that came in from the app. Did you control for probiotics?
I don't know if we specifically looked at probiotics. Oh, Steve's saying no. Okay, so we did not.
Thank you, Dr. Duell. Our last speaker is Dr. Alicia Barbado. She's a research associate at Case Western University in Cleveland, Ohio. She's here to discuss her work regarding G54-2X small intestine exhibit modest inflammation without structural damage.
Well, thank you very much for the invitation to come speak today. And like they said, I'm going to be talking to you about intestinal inflammation in G54-2X mice in small. I have no disclosures. So as we've heard a lot already, GI complications in CF is very prevalent and still a large concern and something we need to look into. With the modulators on the market, lung health has significantly improved, but they do not seem to affect the GI symptoms as much. So a lot of pathologies and symptoms that people with CF complain about are still very problematic. There's lots of different things that could be contributing to the pathophysiology of these GI symptoms. Some of these potential avenues are obviously fluid secretions, with the lack of water being put into the lumen of the GI tract causing constipation, dysmotility or the irregularity of contraction of the smooth muscle causing food and GI contents not to be propelled appropriately through the system. Microbiota and the microbiome changes can definitely contribute to some of this. And my area that I'm particularly interested in is how the inflammation in the GI tract can affect these symptoms. So we've already heard a lot about calprotectin being used as a biomarker for intestinal inflammation. This is a good way to study and get a good idea what inflammation is present, because biopsies and endoscopy is rather invasive. So there's a study that looked at healthy controls, people with CF, and inflammatory bowel patients, and looking at calprotectin levels. And we can see on the right side of the screen, just looking within the people with CF, calprotectin seemed to be higher in individuals that had pancreatic insufficiency versus the individuals with pancreatic sufficiency seem to have a much lower level of calprotectin, indicating there might be some relationship with pancreatic function and inflammation. But when you look at the chart on the left, when you compare the healthy controls, the people with CF, and individuals with Crohn's disease, even though there is a level of calprotectin higher in individuals with CF, it's nowhere near the level that's present in inflammatory bowel diseases. Those individuals have much higher levels of calprotectin and inflammation. On modulator therapy, there does seem to be a decrease in levels of calprotectin over time. This particular study was looking at a duration of a year. So you can see on ETI therapy at baseline, there's higher levels of calprotectin present, but then after 12 months being on ETI, calprotectin levels go down. However, depending on which modulator patients are taking, that trend does not always hold true. Lumacaftor combination therapy doesn't seem to have the same effect on levels of calprotectin that ETI does. And given the side effect profiles that some patients cannot tolerate ETI therapy, and not every person with CF is capable of taking ETI due to the mutations they have, it's still an important avenue to look to see how inflammation is affecting GI health and the symptoms they experience. So we've already heard a lot of very, very cool data in the clinical side of things and how inflammation and dysbiosis affect individuals with CF. So I am using a mouse model to try and help tease apart how mechanistically these symptoms might be affected, and specifically how inflammation might contribute to these, since we don't have to worry about antibiotics and diet in a mouse model. We can control for all of that. So we chose to use the G542X mouse model. They do experience severe obstruction phenotypes. They have to be on laxatives or a special high-fat diet in order to prevent the mice from obstructing. And of note, this is not a problem that goes away in early life of mice. It can continue to be a problem as the mouse ages. So these mice need to stay on the special diet to prevent obstruction. And we chose to keep them on this diet for the study. That way, mice that were obstructing or close to obstructing wouldn't confound our findings. And what we did was we took the entire length of the small intestine from duodenum through the terminal ileum, and we made Swiss roll sections and then looked at those sections histologically
to see if there was any structural abnormalities and see what inflammation was present. And then we also did bulk RNA-seq on the 3 sections of the intestine as well. So to start with, I wanted to look to see if there were any architectural changes or evidence of injury present in the small intestine of the mice. So on the left hand, we can see a small intestine of a CF mouse, and then on the right is a small intestine from a wild type mouse. And one of the first things that I noticed when looking at these sections is there are differences in the crypt architecture. So on the CF image, the red bar indicates the crypts, and we can see a significant increase in size and crypt depth compared to the red bar on the wild type image. So crypts are elongated. The black arrows also show crypt dilation and filling of the crypts with mucinous secretions, which you do not see in the wild type mice. These changes, even though I'm highlighting them on an ileum section, you can see these crypt changes from duodenum all the way through to ileum. And these findings are also similar to findings that you can see in people with CF through biopsies. Another interesting finding that we saw is the wall of the intestine and the smooth muscle layers is significantly thicker in our CF mice compared to our wild type mice. Those changes begin to occur in the jejunum, and as we can see in the ileum by the black bars as well, those also can be seen with thickened wall and smooth muscle layers in the CF compared to the wild type. But of note, even though there are architectural changes, I didn't see any evidence of mucosal damage or injury in these mice. So architectural changes, but no injury. So next we wanted to look at what type of inflammation, if any, is present. So the first thing we wanted to look at was neutrophils. We used an antibody stain to highlight the neutrophils, and you can see these in red. And what we did was we looked at the duodenum, jejunum, and ileum through these Swiss rolls and then counted all of the neutrophils that we saw. So in CF, we can see small clusters of neutrophils present throughout the entire length of the small intestine, compared to wild type, where there's one cell here or there scattered throughout the intestine. And if you look at the counts in duodenum, jejunum, and ileum, there's a statistically significant difference between the numbers of neutrophils in CF mice versus wild type mice. Jejunum seems to be the area where there's the biggest difference, with over 1,000 cells counted in CF versus 125 cells counted in the wild type mouse. And even though there's significantly different numbers of neutrophils, this isn't full-blown inflammation that you would expect to see in something like Crohn's disease. So there is inflammation, it's just not quite to the level that you would see in something like IBD. We also do see some clusters of neutrophils in wild-type mice, which when you compare to humans is a little atypical. You shouldn't see a lot of neutrophils in humans at all. But mice seem to have a little bit, but those are focused around Peyer's patches. And you can see there's little clusters here in the wild type, but when you look at the CF mouse with Peyer's patches, there's still increased numbers of neutrophils present. The next cell type that we looked at was mast cells. So we used a special stain, toluidine blue, to highlight these cells and make them easier to see. It turns these cells a pretty purple color. And you can see those through these black arrows I have pointing to them. There's been studies showing that there are increased numbers of mast cells seen in CF mice. So we wanted to take a look at it and see if we could see that in our mice. We did see elevated numbers of mast cells in the ileum compared to wild type mice. However, if you look at the numbers, it was an average of 32 cells in the entirety of the ileum versus not even one cell in the wild type mice. So even though it is statistically significant,
I'm not sure how actually significant it is because there are so few of them present. So mast cells, they're increased, but not very many. And then the last cell type that I'm going to talk about, which is a little interesting because eosinophils are normally part of the GI tract. They're present. It doesn't necessarily mean it's a bad thing. But when I was looking at the slides, I did notice it seemed to be higher eosinophils compared to the wild types. And then when I actually went through and counted, we do see increased numbers of eosinophils in the CF mice compared to wild type mice. So in the jejunum and the ileum specifically, we see higher numbers. So red arrows in these images are marking the eosinophils. So you can see there's only 2 in the wild type versus many more in the CF mouse. And then the black arrows are just pointing to neutrophils again. So again, only 1 neutrophil seen in the wild type mouse versus multiple in the CF mouse. And then again, we can see elevated eosinophils present in the CF mouse ileum versus the wild type mouse ileum. So to summarize the histology findings, we didn't see any evidence of mucosal damage or injury present. However, there were increased numbers of neutrophils and eosinophils, specifically in jejunum and ileum. And there were statistical mast cell differences, but overall, those cells are very, very rare. So not sure how actually significant those are. And then lastly, we wanted to look at RNA data to see if we could find any differences in the gene regulation between the CF mice and the wild type mice. So we did bulk RNA-seq and looked at duodenum, jejunum, and ileum separately to see if there was anything that we could tease out in terms of the genetic background for these. And jejunum seemed to have the biggest differences, so that's what I'm going to be focusing here. For the upregulated genes, there were genes found to regulate the innate immune system that were upregulated in the jejunum of CF mice compared to the wild type mice. When you look into which genes those are, they're genes that relate to interferon production, epithelial barrier function, LPS response, as well as some antiviral and antimicrobial pathways. And then when we look at what genes are downregulated, we see genes that are related to regulating leukocyte-mediated immunity. And then looking at those genes are related to complement pathways, leukocyte activation, leukocyte proliferation, and a couple interleukins and cytokines as well. So this data was a little interesting because we do see elevated immune cells in the small intestine. However, when we look at the gene data, some of those genes that regulate leukocytes coming into the intestine and proliferating seem to be downregulated. So our next steps, we really want to look at single-cell RNA-seq data as well as spatial transcriptomic data to try and tease apart what's going on with these pathways. So to summarize, histology, we do see increased numbers of neutrophils, eosinophils, and mast cells in the small intestine. We do not see any evidence of injury. So these inflammatory cells are being drawn in by some other mechanism, not necessarily because there's an injury in the intestine. There is some acute inflammation, but it's not overwhelming like we would see in something like Crohn's disease. And the RNA data is a little conflicting. So some of the pathways for immunity are upregulated, specifically with innate immunity, but then other genes are downregulated where leukocyte proliferation and activation are concerned. So I just wanted to acknowledge everybody in the drum lab that helped work on this project, as well as our CF cores that help provide the mice. And I'm happy to take any questions.
Hi, Steve Friedman from Harvard. That was great. And I'm curious on your RNA data, if you saw changes in tight junction expression, because, Bob Delisle must have published, I don't know, 20, 30 papers on all this showing similar results back in 1990s or so. But he saw that there seemed to be, on the RNA side, results consistent with disruption that go along with the tight junctions not being intact, and hence, kind of this leaky gut.
So I didn't specifically look at tight junctions. I basically just pulled out the cells that, or the genes that were related to the inflammatory pathways that the program highlighted. But that is a really interesting point. That'd be something to look into.
And did you try treating, I know they're all on probably PEG solution, but did you try treating with antibiotics and see, does that change morphology or RNA-seq data?
So we have not looked at that yet. This data was mostly just to see at baseline what we could see in the mice, and we still have a lot of other experiments that we would like to do to further try to characterize this. But antibiotics would be a good idea to see if that changes the RNA profile. Thank you.
I have a question for you, Dr. Barbados. The mice are on a specialized CF diet to prevent obstruction. So that makes me think that there could be some dietary components that might play into the number of mast cells or eosinophils. And there could be some implied potential for non-pharmaceutical interventions there. What's your knowledge about the diet and how it might affect the number of cells?
So that's a really good question. So, I think a lot of us know high-fat diets do tend to be pro-inflammatory. So because these mice are on a high-fat diet to prevent obstruction, the inflammation that we see could be contributed to that diet. What we want to do in further studies is to look at different types of diets that do not have high fat and see if this inflammation pattern seems to stay the same. But yeah, I think the pro-inflammatory effects of high-fat diet could definitely be contributing to this. All right, thank you.